Hello and welcome to the Department of Respiratory Medicine at West Hertfordshire Hospital NHS Trust for the educational video on linear endobronchial ultrasound. This case involves 69-year-old lady who has got 55-pack-year current smoking history. She has been investigated for chronic cough initially with chest X-ray and then subsequently with staging CT. She has got good performance status of 0 and normal spirometry. Unfortunately, her staging CT showed left lower lobe mass with left hilar lymphadenopathy. So this procedure will involve both diagnostic as well as staging. All right, dear. Just have a little. Keep your tongue down. Keep your tongue down. Just going to have a quick look and put some local anesthetic.
I'll do
doing absolutely nothing else.
I'll do another one in a minute.
Okay, keep your tongue down for me. Well done. Perfect.
Yeah. Yeah.
Okay, some lignocaine, please.
So this is a technique whereby you're administering topical local anaesthetic
straight onto the vocal cords, not the transcricoidal.
And I guess for anyone naturally, you would expect them to cough.
Indeed. Okay, another one, please. Just 2% is fine.
Well, that's very specialist, isn't it? And the people that are interested are interested.
Okay, dear. We're just putting some local anesthetic that is making you cough because we're trying to numb your vocal cords, and that's quite natural. Takes about a minute or two, and then it will settle down.
So, very nice laryngeal anatomy with the retinoid cartilage on either side being very, very clearly shown. The areoepiglottic folds are nice and crisp. You get changes with reflux, which makes this area very inflamed and puffy.
Another one?
Yeah.
She doesn't have those.
This is something that as gastroenterologists we see in clinic with people who have reflux or have persistent cough, and it's trying to ascertain who are the ones that should come for a specialist opinion, either ENT or respiratory.
Well, to be honest, I would say this, but respiratory consultants probably see more larynxes than anybody else.
Yeah, absolutely. Yeah, I'm sure that's right.
All right, yeah. Just going to put some local anesthetic. Go for it.
So, Ray, the difference here in technique is this lady's had direct application of local anesthetic onto her larynx as opposed to the brachithyroid
inside now, just putting a little bit more local anesthetic.
Local anesthetic.
Yeah. And it is very different.
Did you notice that she coughed a lot?
She coughed a lot
as the
more.
scope went through the cords.
Absolutely.
And that's why we moved to doing the way we do. Yeah. So the quality of the anesthesia is very different, I think.
Yeah.
Yeah, go for it.
So here you're administering
local
anesthetic down the left main bronchus.
Indeed.
Okay.
Okay, dear. Just putting extra local anesthetic. Again, as I said, it does make you cough for a couple of minutes and then it settles down. Another one, please.
So Dr. Mogul will be approaching this case with the view to both stage and diagnose.
Yep.
So understanding that the left-hand side is abnormal in terms of the potential primary, he will have undertake a very careful ultrasound examination
relax now.
of the
You're
right
doing
hand
very
side,
right.
and then move from the right to the centre to the left.
Yes.
So that's interference.
This is interference. This is electronic interference.
That is.
So there's a little bit of electronic interference there. No, that's okay.
No,
the other is to have.
I've seen it before.
Hold on. The filtering. So the compound is on. Doesn't make any difference.
Okay. Fine, relax.
See, that's interesting.
Changes.
So that changes
waveform.
it.
Okay. Let's not make too much of it.
Well, there's something that's giving a little bit of noise.
Oh, it's gone now.
That's a little bit better.
What did you do there?
Yeah, we had the factory, so we've done sharp. So we don't have the factory one, or
Oh, go back.
same one now. Fine, okay. And then smooth. That's a little bit better. Bit more black and white, but.
All right. Yeah.
So as we're doing optimized image, just to reframe the question, so this is a lady in late 70s?
69.
Sorry, late 60s, who's
Yeah.
presented with recurrent cough,
Yeah.
had a chest x-ray and a CT, and this demonstrates a mass in the left lower zone.
That's right.
So the remit here is to use EBUS to scan the right lung from top to bottom.
Yes.
In layman's terms.
Indeed.
To make sure that there are no contralateral nodes.
Indeed.
So to aid staging, and then at the same time, as Andy has said,
To get
to
diagnosis.
get diagnosis.
Yeah. So I'm at subcarinal, station 7. There's clearly a node there, which is about just over a centimetre.
So we'll definitely be biopsying that.
Yeah.
Station 7. So we will be going here.
Yeah.
Okay.
Yeah. So Dr. Mogul's just moved into the 11R station.
Yeah.
So you're just at the tip of the right main bronchus. You're in the right main.
Yeah. So this is right main bronchus, just below the origin of right upper lobe bronchus. So basically, what I've done is I've gone 180-degree clockwise from station 7. So this is station 11R, and as I come gently up, there will be some air artifact, and then station 10R if there is any. There doesn't seem to be, or at least one that I can't see.
And again, you've got a very nice
so we've got
example
some structures here. Can you talk me?
Azygos vein going into the SVC.
Yeah. So this is the azygos vein here, and this is the SVC here, and this structure,
branch of a pulmonary
the right pulmonary artery, azygos SVC. It's very nicely done.
And then slowly come up, keeping SVC in the picture.
So there's nothing in 10R,
nothing 4R.
No. So watching you work here, you're pulling the
keeping
echo
the SVC
bronchoscope up towards.
So that's the brachiocephalic artery.
So let me just highlight that again. So brachiocephalic here.
Yeah. And just to follow that.
And when you say follow, you mean?
I'm twisting
so
to the
so it's gone
left.
from
anti-clockwise.
So it's gone from cross-sectional view to longitudinal view.
So there's a small 2L there.
Sorry, I missed that, Andy.
Just here.
So just looks superficial to the brachiocephalic artery as it goes into the aorta.
Yeah.
Yeah, maybe slightly. I'll take this down a bit.
And that's.
What happens if you bring this back? Oh yeah, it's quite bright, isn't it? And then
that's the brachiocephalic artery into aorta, and then gently coming down. That's
so now the
aorta
pulmonary window, and again there's a small lymph node at the top there.
Yeah, I think it's got central hilum in it. Yeah, it's got fatty hilum. So if you make it big.
So here, yep.
Yeah, so there is, where your arrow is, there seems to be hilum there. Yeah.
Yep.
And it's nicely, you can see rhomboid shape, about 4-5 millimeter in size. So it has got all benign features. And then I will gently push down, keeping pulmonary artery in the view, and that's going to be 10L, but there isn't any obvious node.
Rahul, just there.
Yeah, just going to put some local anesthetic. This is going down the left main bronchus, but I can't see much down there. Got very limited views. It's not doing well. All right, yeah. Nice gentle deep breaths in and out. We give a little bit of Midas. Okay, gonna give you a little bit more sedation. Again.
So once we've done that, so what we've done, just in summary, is you've actually done a complete mediastinal staging.
Yep.
You've started on the right-hand side, down at 11 hour.
Station 7
10
and
hour,
then,
Station 7, 11 hour, 10 hour,
then
4 hour,
4, 2.
and then 2 hour, and then you've
4L,
rotated
10L,
onto, Did we see 2L?
No.
I think there was nothing. And then 4L.
I thought there was a brief.
There was a brief, very brief,
small 2L node.
Yeah.
I'm just waiting for her to settle down. So you can see the clear difference where we couldn't give transcricoidal and she's struggling.
Yeah.
I think she probably would have struggled anyways, but
you can see the difference between the different types of local anesthesia.
All right. I think her left main is also very sensitive, not able to go much further than.
Can we have a 22 gauge standard? Just.
Can we? Can we cut? Can we? How did you do that?
Okay.
Okay. Now we've got this differential here between here and here. Can we go back to basics?
We're going for 7.
Yeah, it's so bright.
There it is, Kara.
Tony, station 7 is the first target.
Yeah.
No, I know.
So, as before, first job is to set the sheath. So it's outside the operating channel of the scope. That means we don't damage the scope. And you can see the sheath appearing at about 1 o'clock on the video screen.
So on the video we can see it's nicely there. Okay. So this is a...
Two nodes seems to be sort of next to each other at station 7.
Yep.
Okay, I don't like that.
So a subrenal space. That's it. Very nicely done. So very nice technique, going all the way from the shallow to the far portion of the lymph node, staying within the lymph node.
Absolutely. A little bit of blood back.
So perhaps you did about 10, 15 agitations there?
Yeah.
All right. Yeah. Nice, gentle, deep breaths in and out. In and out. You're doing so well. Can you get some more lignocaine? Yeah. Is it behind? Yeah, go for it.
Quite bloody.
It's about 3 centimeter, irregular in shape, just with borders.
So this is exactly the same territory.
Yeah. And
so station 7, going down the right main bronchus.
Indeed.
Okay. So needle is coming in here.
Yeah.
There we go.
Now. So
just adding on the suction syringe.
And again, two-handed technique, making sure it's all very controlled.
So nice and slow, back and forth, to's and fro's, or agitations. So this is the second pass, same lymph node, but in a different position.
Well done. Well done. So I'm intentionally just staying.
Just waiting.
Yeah, absolutely.
I think
because
whilst we're doing that, we might be worthwhile pointing out that on occasions an ultrasound scope can pick up electronic artifact, and you can just see these parallel lines here that are rotating. Now this is real world ultrasonography. It does happen, but there can be many reasons for it. It can be that it picks up an external source, for example a wire recording ECG leads. But the ultrasound specialists are always available to be able to help in terms of optimize the image when you commission a new service in the endoscopy unit. What's interesting is that there are some things that the endoscopist can do also to minimize this. So, for example, getting a better apposition of the image.
Yeah.
you can see the artifact is still there, but we have much better views and it's much less distracting.
So that first pass was mainly blood. Okay, I haven't seen pass 2 yet.
So this is pass 3.
Rahul, if I hover superficially, could you just put some tip down, so thumb down?
Thumb down, okay.
Yeah.
So you've got a completely different angle now.
Just trying to get to a slightly different place.
Yeah. Okay. I think
That's it.
it's mainly blood.
This is nice technique, going back and forth.
Okay.
Okay.
Have you been able to get down the left lower lobe?
I think it's very sensitive, and it's probably narrowed as well, because after a certain point I'm not able to get the scope forward. Okay, lost the view. Can you just flush 20 ml through this, just to get some clarity?
Actually, I don't suppose have you got a trap? Could you put a trap on the circuit, please?
Okay, yeah. Not too long now, not too long. You're doing really well.
So we're just trying to clear the field.
Clear the field so you can see where you're going endoscopically. Yeah.
All right, my dear.
I think there's probably a blood clot or something.
Okay,
maybe.
pass 2 adequate, mainly small lymphocytes, very occasional slightly enlarged cells, but I suspect macrophages. So if I was to categorise it, equivocal, probably benign.
Okay. Thanks, Tony.
That's on number 3.
That was pass 2.
Pass 2.
Yeah.
We might have to call it today.
Is there ever a leeway to remove the scope to clean the lens, or would you never do that?
So re-intubation is
always
very
very
tricky.
difficult, especially with her.
They're coming up again now, so 93. It's really difficult.
Do you want to try to see whether you can clear it up?
Yeah, I'll go. You can do it.
It's got oxygen. All right. Okay. How much oxygen she's on?
That's AP window. I'm just going to go down.
So left pulmonary artery.
Yeah. Actually, the pulmonary vein underneath. Let's take this balloon off. We might have to stop. There we are.
There we go.
That's station 7,
station
isn't it?
7.
Yeah.
That's air artifact.
This is the air artifact here.
I think we might need to stop, actually.
I was just going to say she's struggling. We probably do need to call it a day.
Okay.
She's persistently
Okay, stop.
Okay.
Hello, my name's Andy Barlow. I'm one of the respiratory consultants here at West Hertfordshire Hospital's NHS Trust. The point of making this short video here is to demonstrate that this is absolutely a team effort. A complex endoscopy requires everybody to play their part. So I'd like to first of all thank the endoscopy nurse team who are scattered around here in the audience. I'd like to introduce the pathology team.
Hello, I'm Winnie Tang. I'm one of the senior biomedical scientists. I make the slides for the pathologists to look at.
And I'm Dr. Tony Maddox, and I'm the pathologist that she makes the slides for.
I'd like to thank my endoscopy colleagues.
Ray McCruden, gastroenterologist from the Royal Bournemouth Hospital. I do endoscopic ultrasounds, not EBUS, but I'm very flattered and grateful to be asked to be part of the teaching and training today.
And thank you. I'm Rahul Mughal, one of the chest physicians, works at Watford General Hospital, West Hertfordshire Hospital's NHS Trust, and as my colleague Dr. Rahul mentioned, this wouldn't have been possible without the teamwork, and that involves endoscopy staff as well as pathology and Dr. McCruden coming all the way from Southampton. Thank you. Bournemouth, sorry.
So once again, a final thank you to everybody for a fantastic day, and let's look forward to the next training video.